Hello and welcome everyone. Tonight I'm going to go over a quick guide for the EMTs for a cardiology unit exam for Fisdap. Now, understanding a wide spectrum of cardiac conditions is vital for effective patient care and management. And also you have to really understand the difference for these Fisdap exams. So the first thing I want to talk about is left-sided heart failure. Now, left-sided heart failure occurs when the heart's left ventricle cannot pump blood. So it causes it to back up into the lungs because, as we know, the oxygenated blood from the lungs comes from the lungs and goes to the left side of the heart, left side atrium, then left side ventricles, and pumps out to the rest of the body. But when that left side can't pump, it backs up. And where does it back up? It backs up into the lungs. Now, the lungs, the sound of this fluid in the lungs is going to be crackles. Okay, so if you hear questions that refer to fluid in the lungs or pulmonary edema, edema, remember, is just fluid. Now, where it is pulmonary, that means lungs, so fluid in the lungs. Also, don't forget that crackles is what we are calling pulmonary edema now. However, if you hear the word rales, R-A-L-E-S, they are using that interchangeably. Rales is the old term that we used to use for, or that we use for crackles. And so that is also related to pulmonary edema. So you could use those interchangeably. So when you hear the questions such as an elderly female has bilateral rales, meaning both sides rales, what do we expect? We expect, of course, pulmonary edema. Now, as I said, they use rales and crackles interchangeably. And so an elderly patient who has left-sided heart failure, what lung sound should you suspect? And of course, you're going to get 4 answers, and none of them are rales, but one of them are crackles, and so of course you'd pick crackles. Now, I do understand that this creates a little bit of slight confusion, but just remember, lower lung sounds that are wet are going to be described as crackles or rales. And unfortunately, in this exam, I think you're going to see both of those. Not in the same questions, though. Okay, so let's move on to the next side, and that's going to be the impact of left-sided heart failure. Of course, we talked a tiny bit about that. You're going to have shortness of breath and fatigue, and the key thing here is the pulmonary edema because the fluid is backing up into the last area where it was, which was the lungs. Okay, so remember, left side, always oxygenated and always coming from the lungs. Now, that leads us to the 4 chambers, or talking about the anatomy of the heart. You're going to have to know the anatomy of the heart. So just remember that the top 2 areas are the atria. I always think of the top chambers as an atrium, relating to kind of like when you're walking into a building, you're seeing an atrium. And then the bottom 2 are going to be the ventricles. Now, each chamber is going to play a vital role in the circulation of the, whether or not it's oxygenated or deoxygenated throughout the body. So don't forget, the left side is going to be oxygenated. The right side, or the patient's right side, is going to be deoxygenated. So let's look at some questions that refer to the anatomy. Okay. So if you see a question that asks how blood flows through the heart, you could start at the right atrium. Remember, it's above, to the right ventricle, always right to right atrium to right ventricle, then to the lungs, and then to the left atrium, to the left ventricle, and then, of course, to the aorta and to the rest of the body. Now, just remember that the right side is deoxygenated, it's blue blood, and it has to go to the lungs. So right goes to the lungs. Okay, so continuing further with the anatomy of the heart, let's talk about the chambers again. The right side, do not forget, it's deoxygenated. The left side is going to be oxygenated. So if you're asked about a chamber, which chamber is going to pump the oxygenated blood out of the body, it's going to be the left side, without a doubt. And you know that the lower one is going to be the ventricle, and so it's going to be the left ventricle, and that's the powerhouse of the heart, that big, thick, muscular left ventricle. That is going to be the chamber of the heart that pumps oxygenated blood to the body systems. All right, so when we talk about the valves of the heart, now these could get a little bit tricky. However, I always refer to the valves of the heart, and I think about how many lobes the lungs have. If you remember, the right side has 3 lobes, and so that's tri, and then the left side of the body has 2 lobes, and that's the lungs. So 3 lobes on the right side, 2 lobes on the left side, and I relate that to a lot of things in the body. So if you want to know about the valves, there is a tricuspid valve. That's going to be 3. So the tricuspid valve's on the right side of the heart, and then you have the bicuspid valve, which is on the left side of the heart. And another name for the bicuspid valve is going to be the mitral valve. Also, you have the pulmonic and the aortic. Now, these valves are named after where the blood is going to. So the pulmonic valve is at the opening of the pulmonary artery, and the aortic valve is, of course, at the opening of the aorta. And so if you had to name the 4 valves of the heart, it's going to be the mitral, in parentheses, bicuspid. Then you have the tricuspid, you have the pulmonic, and the aortic valve. Okay, so I think that we've covered a little bit of the anatomy, so let's move along. We're going to move to the cardiovascular system function. So the system works synergistically with the heart to circulate blood, nutrients, and oxygen throughout the body. So understanding the system is very critical for assessing and treating cardiac-related issues. Now, let's talk about what is the most common complaint of patients with cardiac compromise. Now, they're going to complain of dyspnea. Now, dyspnea is difficulty breathing. You could look at that word, and DYS is the difficulty part, and the PNEA, now that is lung related, so difficulty breathing. Okay, so you guys are going to see a lot of things related to acute coronary syndrome, ACS. Now, this could be, I always describe ACS as an umbrella term, which a bunch of different words lie underneath. So unstable angina, or angina in particular, we're going to talk a little bit about. Then STEMIs, so whether or not they're non-ST elevation, that's a little bit too much information for you guys, but just understand it. STEMI is a ST elevation myocardial infarct, and so the MI, or the myocardial infarct, you're going to see a lot of that, and all of them are caused by a sudden reduction of blood flowing through those coronary arteries. And so we're going to talk a little bit about some questions that might be related to acute coronary syndromes, okay? Okay, so if the question is asked, why do patients with cardiac compromise or some type of acute coronary syndrome have chest pain? Please remember that it is because there is not enough oxygen going to the heart or the myocardium. But simply put, it's just not, the muscle is not getting enough oxygen. Remember that these arteries that are narrowing, or that are not enough oxygen are getting through, those are the coronary arteries. And so that is what we're trying to vasodilate or vessel dilate, open up when we give nitro. Now, so if the question is asked when we're administering nitro to a patient who has angina, now remember, angina is chest pain. What structures are we hoping to alleviate with the ischemia? We're trying to open up the coronary arteries. Now, when we vasodilate those coronary arteries, we're trying to reperfuse the myocardium of the heart, right? Okay, so angina. Let's talk a little bit about angina. Angina, in the simplest terms, means pain, okay? So angina pectoris is the muscle pain, that area pain. Okay. Another thing, just really fast, most of the time we're going to consider all chest pain as a myocardial infarct or MI or acute coronary syndrome. However, there is angina pectoris. Now, angina pectoris is a narrowing of an artery, and it's caused by an increase in exercise or an increase in oxygen demand. So if when the person is doing exercise and they have a sudden onset of chest pain and then they rest and the chest pain goes away, we consider that angina pectoris. So that is one thing that you should probably keep your eye out for as well. All right, so moving on. Now let's talk about some complications of the electrical injuries. So electrical injuries can disrupt the heart's normal electrical activity. It can lead to arrhythmias or cardiac arrest. And so we want to make sure that we understand defibrillation, and it's necessary for survivability. So let's talk a little bit about electrical activity. Okay, so first let's talk a little bit about where the first electrical impulses come from in the heart, and that's going to be in the upper right chamber. That's the SA node, the sinoatrial node. Remember, it's the right atrium is where the first electrical impulses stimulating the heart is located. Okay? Also, when we're talking about cardiac dysrhythmias, or remember DYS is difficulty or bad arrhythmia, so bad rhythm, will the AED defibrillate? Normally, I tell my students that it's right in the word. You could look right at it. You are D or stopping, DE, fibrillation. So fibrillation is usually the thing that they're asking about. So what cardiac dysrhythmia will the AED defibrillate? Well, of course, it's normally ventricular fibrillation that we're trying to defibrillate. However, they are going to mention ventricular tachycardia as well. Now, that's another rhythm. The ventricular rhythms are going to be able to be defibrillated. So you can't just generally say it's a fibrillation rhythm or a ventricular fibrillation. That is a good way to remember it, though. However, also remember a ventricular tach is another rhythm that the AED is going to be able to defibrillate. And then talking a little bit about the AED, make sure that if you see a question and it says something about what should you do when the AED is trying to perform that rhythm analysis, make sure that everybody's clear of the patient. Even tapping the patient can cause some type of rhythm analysis issue. So you want to make sure everybody remains clear of the patient. Okay, so I want to pull this back and I want to reiterate the fact that left-sided heart failure occurs when the left ventricle cannot pump effectively, so it leads to pulmonary edema. Now, it's going to cause shortness of breath and fatigue, coughing. You could actually see them cough up pink frothy sputum. Now, I wanted to reiterate the left side. I know we already talked about that. It's a big thing you're going to see in this Fisdap exam, but you're also going to see some right-sided questions. And so when it comes to right-sided questions, sorry about that. Right-sided heart failure, so the right ventricle fails to pump the blood effectively. Now, you're going to have retention in the body, and so it leads to swelling in the legs and in the belly. And so I just want you guys to understand that edema is edema, no matter where it is. Please learn that term. Edema is fluid. Now, if you have a thing called pedal edema, now that is going to be fluid lower extremity edema or peripheral edema. And so that's going to be right-sided heart failure. Okay, so some of the questions you might see with the right-sided heart failure are going to be related to pulmonary edema. They're also going to be related to a situation where you see jugular vein distension. And so that is another thing that you need to understand. The jugular veins are in your neck, and they are coming down from the head. And so just understand that it's going to cause some distension if it's going to be right-sided heart failure. Okay, so if the patient is presenting with pedal edema and also abdominal distension, what chamber is failing? So it's going to be the right ventricle. Remember, the right atrium is, the atriums are just there kind of as a holding chamber. They're not really muscular. If you have failing issues, it's going to be the ventricles. So let's say if you have the pedal edema with the abdominal distension, it's going to be the right ventricle. Okay, and so that's easy. Right ventricle, pedal edema, and jugular vein distension, and also they're saying some abdominal distension as well. Okay, so let's talk about another question you could see. So let's say some type of patient complains of difficulty breathing. Now she has jugular vein distension, JVD in parentheses. Pedal edema. What chamber of the heart do you think is weakened? And of course, it's going to be the same as the last question we just heard from, the right ventricle. So I hope that clears up the right and the left sides. Left side, pulmonary edema. Right side, jugular vein distension with pedal edema, abdominal distension. So let's move on now, and you are going to see some things related to strokes on this test. Now, please understand that when you have a stroke, it is an infarct, and it's very similar. It's a vascular infarct. And so just like your heart, your coronary arteries, except for you have some type of vascular infarct in your head. Now, you have two different types of strokes, very, very simple. Ischemic, if you see the word ischemia, that means a blockage of oxygen. It's an oxygen deprivation. So ischemic strokes are the most common type, and they are way by far 87% of all the strokes. They occur when the blood is blocked from a clot, and it leads to a reduction of blood flow, and of course then oxygen delivery to the brain tissue, and then ultimately death. Okay, so make sure you understand that strokes happen in the head, and they happen when the vessels are blocked. Okay, so let's talk about some of the questions you might hear when it comes to strokes. Okay, so this is kind of a hard question. However, let's say that you get called to a person who has been on the ground for an unknown period of time, obviously a little bit because he has some pressure sores. Now, he's having difficulty swallowing and difficulty talking. These are all signs of a stroke. So an unknown downtime. He's been on the ground for a while, unable to articulate or take care of himself. You don't know when this happened. You could suspect a stroke. That's a kind of a hard question. However, you could see how it would be a stroke more than it would be chronic obstructive pulmonary disease or kidney failure. They try and throw you off with pressure sores and a UTI, but think of strokes. Okay, so we talked about the most common type of stroke, which is an ischemic stroke, and that's the blood clot. However, there is another type of stroke, and that is going to be a hemorrhagic stroke. Now, they're less common, but they are more severe, and they have a higher fatality rate. They result when the vessel ruptures. So it causes bleeding, and that bleeding causes pressure on the brain tissue. Now, like I said, it's going to be less common, however, more deadly, a higher fatality rate. So let's talk about what you might see, question related to hemorrhagic stroke. So say that you have a female, she's unconscious, all of a sudden, and they said, hey, 1 minute she was fine, and she started to complain of a very bad headache. Now, that's a key term here in real life when you're on the ambulance or fire truck, and then also when you're taking these tests. If you see any questions that say they started to complain of a severely bad headache and then went unconscious, you know it's a hemorrhagic stroke, okay? Vital signs, if you were to see a hemorrhagic stroke, what would you think? Of course, pressure's building up inside the head, and so vital signs are going to be higher. Now, if they give you a vital sign on a Fisdap test, pay attention, because there's some reason why they're doing it usually. Now, 178 over 120 is the blood pressure. Absolutely increased intracranial pressure, or ICP. And then they're going to tell you the respiration rate is 10 and irregular. Right away, if you see a lower respiratory rate that's irregular, suspect an increase in intracranial pressure, the answer to that is going to be a hemorrhagic stroke. Now, there's if you have the choice between hemorrhagic stroke or some type of ischemic stroke, the key indicator here is going to be the bad headache and the high blood pressure. And that's going to right away clue you into the fact that it is a hemorrhagic stroke. Now, I also want to talk to you about transient ischemic attacks, or TIAs. Those are also strokes. The key thing for TIA, though, is the symptoms alleviate within 24 hours. So complete symptom alleviation within 24 hours. And that's a TIA. Okay, so I want to go back to this slide, the cardiac condition slide, and talk a tiny bit about a couple more things. The first one I want to talk about is going to be the aortic aneurysm. Now, the aorta runs off the left ventricle. It's the tube that catches all the pressure from the left ventricle. When that tube starts to separate and rupture, I always think of it like a garden hose that is kind of bulging, or there's an imperfection on that garden hose because of an increased pressure. Now, that is what I want to tell you, that in real life and on these tests, whether it be the Fisdap test or the national test, if you hear or see anything that says tearing, so let's say a male complains of chest pain, and it's a tearing, that's how it's described, tearing chest pain. Or if he's been in any motor vehicle accident and his chest hit the steering wheel and now he's saying it's a tearing type pain, what do we suspect? Now, that's going to be an aortic dissection, okay, or dissection, sorry, an aortic dissection. Now, any type of aorta tear or aortic aneurysm, aortic dissection, those are going to be extremely painful. So that's your key. Instead of describing it as chest pain or a type of pressure, it's going to be a tearing or ripping. Okay, so here's another type of question you might see. A person describes sharp tearing pain in his abdomen and back. So that is going to be an area 2. Blood pressures are in his left arm are 114/40. The other arm, so the right arm, is going to be 60/0. Now, that is because the aorta is dissecting. So you could think of that as an aortic dissection. You're going to get varying blood pressures in the arms, but right away when you see the tearing pain, if it's in his abdomen and back, that is still the aorta. Remember, the aorta loops up off of the left ventricle and comes down and runs down through the abdomen. And that's why if you see a pulsating mass in the abdomen, you could suspect an aortic dissection as well. Okay, so we talked about aortic aneurysms. I also want to talk to you about emboli. So an emboli is a type of clot that has traveled. I know that we are talking about the cardiac chapter. However, they want you to understand some of the other conditions that could be related to, to the chest area. and be able to rule in or rule out other mimics. But on this test, when you see chest pain on the right side, now, chest pain on the right side, we want to start thinking a little bit about the lungs. And remember, left side usually is going to be the acute coronary syndrome, the myocardial infarct. However, when you read anything about anybody who's had a recent surgery or trip, any type of long periods where they've been laying flat or still, like hospitalized or long airplane rides, I want you guys to start thinking about the fact that people get clots in their lower extremities. Now, these clots in their lower extremities, or deep veins, deep vein thrombosis, when those clots travel, they travel to the lungs. And so this is going to create some type of severe sudden onset of chest pain. Now, if you get some type of question that says somebody complains of chest pain on the right side and she has just had her hip replaced a couple weeks ago. Now, what would you suspect? What you should suspect is a pulmonary emboli or an embolism. An embolism is a clot, and in pulmonary in general, this is going to cause a lot of pain. So the key thing here for these questions are going to be hip replacements or some type of recent plane trip, or, they were in a long, some type of long journey in a car where they had been sitting still for long periods of time, and long enough to where blood can clot in their lower extremities. Okay, now one last thing I want to talk to you guys about is treatment aspects. Now, of course, we always want to have them on oxygen. However, I want to talk to you guys a little bit about when in this Fisdap exam, they really do talk to you a lot about administering aspirin. And so make sure you understand that we are administering nitro and aspirin, or aspirin and nitro. So if you get questions or see questions that say that somebody's complaining of chest pain and that they have pain 9 out of 10, and then all of a sudden they took their nitro and it's decreasing, vital signs are good. However, what should you do? Now, make sure you're giving them aspirin, because they're trying to lead you, to give them high flow O2, and of course you would assume that you should do that, but make sure that you're giving aspirin as well. There's a couple of really interesting aspirin questions. You would assume that it would be giving them, oxygen, but they're wanting you to give them aspirin. Let's see. Okay, now another one that talks about aspirin is you have somebody who has some chest pain after doing yard work, and he's telling you that the pain has subsided slightly. Now, slightly is the key term here, and they want you to administer aspirin to him as well. Yes, so talking a little bit more about aspirin, how about you have a male who complains of chest pain? He's pale, warm, dry. He has a 20-year cardiac history of taking a blood pressure medicine. So they tell you his vital signs are going to be too low to give nitro. And so what should you do? Now, give him aspirin. And do not forget that the dose of aspirin is 324 milligrams. And so it's going to be correct. Do not let that scare you when you see the actual number of 324. You can't give them nitro. So make sure you're giving them aspirin. Okay, there's going to be a lot of scenario type questions about simple things about chest pain, and then they become pulseless or stop breathing. Of course, you're going to begin CPR and attach the AED. And so just read the question. There's going to be a couple where there's maybe a test question that says something like you cannot assess a radial pulse. So what should you assess or what should you do? Make sure that you're trying to assess a carotid pulse. Of course, if we can't assess a radial pulse, and bystanders tell you somebody's been down for 10 minutes, and well, what should you do? They're gonna try and trick you about doing CPR or applying an AED, but just assess the carotid pulse. Make sure you're reading these questions really well. Okay. Let's see. Talking about nitro, you have to get a blood pressure prior to giving any nitro. Okay. The nitro cutoff is 100, and so the test is really going to try and get you with that. Make sure that the blood pressures are high enough. And let's see. Also, don't forget, you really need to know the American Heart Association CPR. Remember that the steps that you're going to perform for CPR. So if you have a female who goes unconscious, she's apneic, not breathing, and pulseless, what are you supposed to do? Just how you have been trained. You're going to begin CPR. As you're performing CPR, somebody is applying the AED. So you don't just apply the AED. You're going to begin CPR first, and as you're doing the CPR, the AED is being applied. Also, for whatever reason, there are some hypothermic questions on this cardiac test. Now, when you see the hypothermic, so low heat, low temperature questions, make sure that you handle the patients carefully and that you are placing them gently on a backboard. When you are transporting them, you're carrying them on a backboard, you're handling them very gently. Now, this is because the patients can go into, you could hurt them. However, they can go into ventricular fib or ventricular tachycardia because of the hypothermia. So be sure that you're handling them very carefully. Okay. All right, so in conclusion, make sure that you understand the way that blood is flowing through the heart, where the electrical activities are coming from, that right upper chamber, right atrium. Make sure that you're understanding that you give aspirin as well as nitro. You can't give nitro with erectile dysfunction, but you can give aspirin. Make sure that you understand ventricular tachycardia. Also, ventricular fib are going to be shockable rhythms, that dyspnea or shortness of breath comes with chest pain. A common side effect is hypotension with nitroglycerin. So low blood pressure is very common with nitro. So you got to make sure that you check the blood pressures every time you admit it. You also, contraindication is that erectile dysfunction medicine. Okay, so good luck, and let me know if you have any questions. You could put it in the comments, and I'll try and answer your questions in the comments. All right, everybody. Thank you.